Good evening, everyone. On behalf of the Society of Intensivists Bangladesh and our global partners, I'm Dr. Asina Jahan Lopa, and it's my pleasure to warmly welcome you all to this global webinar on the Surviving Sepsis Campaign Guideline 2026 update, focusing on adjunctive therapies. Sepsis impacts patients worldwide, and every update we share today has the potential to save lives. It is truly an honor to moderate this distinguished panel of global leaders in critical care. To formally commence the session, it's my great privilege to invite our respected Professor A.K. Kamrul Huda sir, who is the President of Society of Intensivists Bangladesh, to deliver his welcome speech. Over to you, sir.
Thank you very much, Dr. Hasina Jahan Lopa. I congratulate you. On behalf of the Society of Intensivists Bangladesh, SIB, I want to welcome to all of you, the distinguished guests and the audience, who are the members of the Society of Intensivists Bangladesh, SIB. All of us, you know, the sepsis is a serious global problem and taking many lives each year. It's very difficult to detect and treat the patient within the very right time. So every step forward matters. It seizes many lives from our society. Now, as we focus on therapies and new sepsis guidelines 2026, we have new hope. We can look forward. We can see some lights at the tunnel of the end of the tunnel. So I am honored to welcome the World Federation of Intensive and Critical Care, the Ceylon College of Critical Care Specialists, the Indian Sepsis Forum, and the Asia Pacific Association of Critical Care Medicine. We are very much honored to have Dr. Javeri Fernandez, President of WFICC, as our patron, and Dr. Richard Ferrer, who is the author of this new guideline, along with our esteemed panelist. We can see the Subhash Prasad Acharya. He's from Nepal. Anushka Medalik is from Ceylon College. Pradeep Ranganopa, he's from Critical Care, Indian Society of Critical Care Medicine, Manipal Hospital. Yash Javeri, he's a director, Indian College of Emergency Medicine, and very known to us, our very esteemed member is the Tahsin Salam, Dr. Tahsin Salam. He's the organizing secretary of our Society of Intensive Care Medicine, and he's the consultant of intensive care unit of United Medical Hospital. So in this session, I like to welcome to all of you, and together let us make this session meaningful. Once again, I welcome to all of you for the session and make the session most successful and meaningful one. I like to hand over my microphone back to our moderator, Dr. Asina Jahan Lopa, who is the senior care consultant and working at Uttara Specialized Hospital, Dhaka. Thank you very much.
Thank you, sir, for your warm opening words and setting the tone for our session. So now I'd like to invite Dr. Javier Perez Fernandez, who is the president of World Federation of Intensive and Critical Care, whose leadership has been instrumental in shaping critical care worldwide, particularly through the World Federation, with whom we have closely collaborated for a long time. Dr. Javier, we are eager to hear from you.
Thank you so much, Dr. Lopa. Thank you, everyone, for being here tonight. This is great to see the collaboration in the region. The representatives from Bangladesh, from India, from Sri Lanka, from Nepal present here. With me today is Dr. Jorge Hidalgo, past president of the World Federation. And he's quietly there, but I promise you he's not so quiet when you let him talk. He's been instrumental on many of the processes that we have today, and is actually a leader on guidelines for sepsis, but the ones that we're not mentioning tonight here, because I think that's what really is going to be happening tonight on this seminar is Dr. Richard Ferrer, who is a leader on the sepsis world, is going to give you a little of a summary and a little bit of a wrap up of what the new guidelines represent for sepsis. Sepsis is definitely one of the major aspects for our care in critical care. And as you know, sepsis essentially is the culprit for one death every 3 seconds in the world. So, and the time that I'm talking here, a lot of people will be dead because of sepsis. And I think it's important for all of us to recognize this problem. It's also important for all of us to collaborate in events like the one that we have in here tonight. And that's why, for this reason, I applaud the Bangladesh Society for this initiative, and our colleagues from, again, India, Nepal, Sri Lanka, and Spain, with regard being representative, as well as from the World Federation, to be here tonight and they're able to enhance our education efforts and to promote, again, more knowledge about sepsis. So I really want to thank you, everybody. I know that every one of you personally, because I know all of you personally, are leaders on this field. I know that every one of you is doing an amazing job in promoting care for our intensive care units, for our critical care. So I really cannot say more words than appreciation and thank you, all of you, for what you do. So without more, Loba, it's all back to you.
Thank you so much, Javier, for your thoughtful words. But I can't wait to hear some words from Dr. George Hidalgo. Actually, he doesn't need any introduction. He's always there with us in any conference, any webinar, and he's working with WHO, he's working all the society, he's in the guidelines and all. So I think as a team, we can do something big. And actually, for that reason, in the Southeast Asian region, we want to collaborate more and we want to see more things growing better. So over to you, Professor George Hidalgo.
No, thank you, Dr. Lopa, and the entire team that put together this great effort. As Dr. Javier Perez mentioned already, it's our great responsibility as World Federation to stimulate this participation and to talk about sepsis, one of the most important conditions that we, as an intensivist, deal every day. Mean that I believe those type of forums are critical for us to increase our understanding and also to discuss the latest developments in relation to sepsis. Mean that I wish you a very successful meeting, and as Dr. Yash said, we can have also some conclusions at the end that we will be able to publish some papers and have some opinions in relation to the latest Surviving Sepsis campaign. Mean that thank you very much, and Javier, Dr. Perez Fernandez, and myself, and also Ricard and the World Federation, it's everybody is eager to collaborate with the region.
Okay, thank you so much, Professor George Hidalgo, for your invaluable words. So now let's move on to the heart of today's session. It's my great honor to introduce our keynote speaker, Dr. Ricard Ferrer, one of the leading voices behind the Surviving Sepsis campaign guideline. He is the head of intensive care at Valdebebron University Hospital, Spain. Dr. Ricard, we are so happy to have you with us today. May I now invite you to deliver your keynote address. The floor is yours, Ricard.
Thank you very much for this nice introduction. It's a pleasure to be this afternoon or this evening together with you. I'm going to cover the topic of the guidelines. I'm going to focus in the most sick patients, and also insist about the adjunctive therapies that you will see that we have some, let's say, controversial recommendations in the guidelines. So as Javier and Jorge insisted, sepsis is associated with close to 50 million cases per year in the world, and 11 million people will die. And some of them, of the survivors, are going to have long-term consequences. So we have to try to decrease mortality. And regarding the pathophysiology, I remind you that this is the adaptive response to an infection. So inflammation and increase in tissue permeability is something adaptive. It helps to control the infection, but in the patients that have sepsis, immunological response is dysregulated with, in general, let's say, excessive inflammation, excessive activation of coagulation, and increase in endothelial permeability. And this leads to organ failure, organ damage, and death. So the call for action and the idea is to stop these deaths by prevention, which is very important, vaccination, early recognition of sepsis and early therapy, risk stratification, admit the patient in the ICU as soon as possible, improve the process of care, and the sepsis codes are important in that way, and then precision medicine, where maybe adjunctive therapy is more focused in precision medicine. So Ryan Sepsis campaign started in Barcelona more than 20 years ago with a declaration. And this declaration, this statement, was enforcing the idea that sepsis needs a specific approach, specific therapy because of this high mortality and morbidity. Then the guidelines were developed, the first edition of the guidelines, and we are in a continuous process since the Barcelona Declaration of implementation of these guidelines and education. So this is the timeline. Barcelona Declaration was in 2002. We have several editions of the guidelines every 4 or 5 years. And also we had at that moment a huge database where we published some papers and we can demonstrate reduction in mortality associated with guideline implementation. So more guideline implementation, less mortality. And we show this in different.
Sorry to interrupt, Dr. Rickard. Actually, the slides are not in full screen and it's not moving. Can you just check?
Okay, I try to correct that.
Yes.
Okay. Are they in full screen?
Yes, it's full screen, right? Yeah,
It's full screen. Okay.
Okay, sorry about that. So I was saying that we started with the guidelines in 2004, the first edition, and since now every 4 or 5 years we have published a revision of the guidelines. So for the last edition we have 129 recommendations, which is a lot. Also, we prepare bundles. You know that bundles are a collection of recommendations of the guidelines that have high level of evidence. And the first bundle was published in 2012. Then we modify in 2016, and last version of the bundles is from 2018. So we don't have a bundle for the last 2 versions of the guidelines. In fact, 2021 and 2026 do not have a bundle. But the first hour bundle, 1 hour bundle, is still active. And I think that guidelines have not changed these, and we are still, this is still acceptable that in 1 hour we have to measure lactates, obtain blood culture, start broad spectrum antibiotic, begin fluid resuscitation, and apply vasopressors if needed. But I want to stress that in this edition of the guidelines, for first time, we have a suggestion in favor of sepsis code. For me, this is critical because this is a multidisciplinary teamwork to work together to recognize sepsis and to implement in the early fashion the different recommendations of the guidelines. So this is very positive that for first time the guidelines recognize the need or a sepsis code or a sepsis fast track for the management of sepsis. If we focus in the most severe patients, which are those with refractory septic shock, the mortality could be up to 71%. The main problem with that is that we don't have a definition for refractory septic shock. So 1 day after the publication of the guidelines, also we published this manuscript where we work trying to define what is refractory septic shock. And still, after this Delphi consensus, we didn't achieve a definition, but we agree that for defining a patient with refractory septic shock, we need to say that the tissue perfusion is compromised, so patients have elevated lactate and prolonged capillary refill time, that the patient is completely resuscitated and is not fluid responder, that the patient is needing vasopressors at high dose, and we said norepinephrine base above 0.5 mic per kilo per minute, and the patient has an echocardiography for the assessment of cardiac dysfunction or any other cause that can explain the shock situation. So this is the first step, and in the accompanying abstract, the authors stress that this is the first step. Now we have a consensus, but need to be validated and need to be implemented in randomized controlled trials to assess the best therapies for refractory septic shock. So now we have guidelines, and we have a better definition of what is refractory septic shock. So both papers, I think, that were published with 2 days of difference, 1 day of difference, are important. So if we are focusing in the most severe patients, it's important to check that the patient has the pillars of sepsis therapy done in the right way. And the first pillar, of course, is antibiotics. In this edition of the guidelines, we have changed a little bit the approach, not too much. We said that if the patient has sepsis or is in shock, we need to administer antibiotics immediately, ideally in the first hour. If the patient is not in shock and we think sepsis is definitive or probable, the antibiotics again should be administered in 1 hour. Only if sepsis is possible, and we don't consider probable, we consider it possible, then we have a period of 3 hours for reassess the patient, look for an alternative diagnosis, and if there is not alternative diagnosis, then start antibiotic. My question mark here, because I am author of the guidelines, but also I am critic with certain points, is what about immunocompromised patients? Because immunocompromised patients, you know that time is even more critical. In this paper, in neutropenic patients, they could demonstrate that 30 minutes are important. So delay of more than 30 minutes imply higher mortality. So, of course, the guidelines do not assess every type of patients, but if we can modulate this a little bit, I will question that in patients which are immunosuppressed, immunocompromised, this time of 3 hours, even you think it's only possible, I will escape that and will give antibiotics in 1 hour in patients who are immunocompromised. And then there is a list of modulation of these empirical antibiotics, including, of course, that you have to assess the risk for multi-drug resistant microorganisms, and there's a suggestion to use broader coverage for the patient that have risk of multi-drug resistant, and of course, not use it if the patient do not have this risk. Antifungals are not suggested in the guideline as a general approach, but importantly, in patients who are immunosuppressed, this have to be personalized. And a new recommendation is regarding the use of antibiotic which have an anti-anaerobic profile. And I want to discuss a little bit more about that, because there are some papers showing that if you don't think that the patient has an anaerobe, we are suggesting not to use anti-anaerobic coverage. So sometimes for respiratory infections, for example, we use piptazo or we use a carbapenem. We have to look for better alternative, because damaging the microbiome with anti-anaerobic antibiotics can be dangerous for patients. So this is the first time we have this suggestion against of the use of these antibiotics. Of course, if you don't have alternative to carbapenem, we have to use it. If we are thinking in abdominal source, we have to use it. But if we are talking about conditions where anaerobes are not involved, we have to look for alternative antibiotics instead of using antibiotics that cover anaerobes. Regarding hemodynamic fluids, at least we have to be convinced that we have covered the basics. So in the first hour, we have to measure lactate and capillary refill time. We have to start in the first hour fluid resuscitation, and in 3 hours we need to achieve 30 ml per kilo of crystalloids, mainly balanced solution. But this edition of the guidelines, we have considered many things. It's not that every patient should receive 30 ml per kilo. We add some remarks, especially for patients that do not tolerate 30 ml per kilo because they have cardiac dysfunction. And of course, if the patient is not responding, and there is a strong recommendation in favor of using norepinephrine as first-line vasopressor. Start peripherically if you don't have a central line, and target 65 MAP, except those patients that have older age. It was the belief that patients, hypertensive patients or patients with age above 65 may need a higher target, but in the last papers, this has been demonstrated harmful, in fact. So now the suggestion is that patients above 65, the target can be 60 instead of 65 for the general population. Another suggestion we have maybe is peculiar for you, which is the use of arterial line. In my thinking, arterial line is a standard measure for monitoring blood pressure in sick patients, especially those that also need frequent blood analysis sampling. However, when we analyze this in the guidelines, we found that really there are no papers showing benefit that using arterial lines change the outcome of the patient. And we can discuss more about this in the discussion period, but we have now a suggestion saying that invasive or non-invasive blood monitoring is an alternative. So in the remarks, of course, we insist that those patients with high dose of vasopressors, etc., probably arterial line is needed. But if the patient is not in this condition, arterial line can be skipped. And regarding source control, we revisit the topic a little bit, and now we suggest a window of 6 hours for source control. So even the patient is very sick, we have to confirm that the patient is receiving the right antibiotic, the source control is completed, and we have a good hemodynamic monitoring as the basis. If we go for more advanced therapy, and I'm going to cover different topics a little bit more complex, we know those patients that have damage in the glycocalyx and damage in the endothelial cells, and the recommendation of 30 ml per kilo. And I'm going to ask some consideration. It's not just that the patient tolerate the 30 ml per kilo. There is evidence that too much crystalloids damage additionally these glycocalyx, and the biomarkers of glycocalyx damage, that like Syndecan, are increased when the patient receives a lot of fluids, a lot of crystalloids. So why not albumin? And because albumin has a better endothelial profile. However, in this edition of the guidelines, probably albumin has been a little bit downgraded because now the suggestion is to use crystalloids, and crystalloids better than crystalloids with supplemental albumin. And we have to go for the remark, where in the remark is said that the use of supplemental albumin may be appropriated for patients who already receive large volume of crystalloids or patients that have cirrhosis. So albumin has been, despite I think is a better endothelial fluid with a better endothelial profile, the recommendation for albumin has been downgraded a little bit. What about vasoplegic patients? You know, vasoplegia is associated with low tissue perfusion, is associated with the production of nitric oxide at the endothelial cells, and this production of nitric oxide can be inhibited by several of the therapeutic options that I have in this slide. However, just inhibiting the synthesis of nitric oxide increase blood pressure, but may increase mortality. And I always insist in that, because we have to differentiate which is blood pressure and which is shock. Probably those patients in this trial improve blood pressure, but worsen tissue perfusion because the circulation in certain territories are compromised with the use of this nitric synthase inhibitor. What about methylene blue? For methylene blue, we have some good news. It's small studies, but some new small studies like the Ibarra-Estrada study in Mexico produce some positive results in terms of mortality, but also in terms of morbidity. So this has been visited in the guidelines and is the only recommendation that refers to patients with refractory septic shock. The rest of the recommendation are for sepsis and septic shock. This is the only one, methylene blue, that goes for patients with refractory septic shock. And the conclusion we have when we looked at all these meta-analyses is that we cannot recommend in favor or against. So the evidence has been checked, but there is insufficient evidence for saying a suggestion or a recommendation in favor or against. So my perspective is that if you have methylene blue available and you have a patient in refractory septic shock, if you use a personalized approach in some patients, you can use it because the guideline or the evidence, the analysis of the evidence was not able to say this is harmful or this may benefit. But of course, not a general recommendation, but for a specific patient. You know that also vascular tone at systemic level is very complex. Here you have a slide with the three axes that control vascular tone at systemic level. This is complex. All three axes have specific receptors in the endothelial cells and then smooth muscle cells. Some of them alpha-1 receptors for adrenaline, noradrenaline, and B1 for vasopressin, AT1 for angiotensin. And the three types of drugs has been used in the setting of sepsis. Guidelines insist that norepinephrine is the first-line vasopressor. So it's the drug that we need to use, and this has been carried over from the previous guidelines. Some topics has been revisited, and especially vasopressin, that the suggestion now is that use vasopressin when we are escalating the dose of norepinephrine, and the third line vasopressor, according to the guidelines now, will be the use of epinephrine. So epinephrine, I think, has been have increased a little bit the level of recommendation, saying that norepinephrine plus vasopressin or epinephrine are good alternative, especially when the patient has cardiac dysfunction. So if the patient has cardiac dysfunction, norepinephrine or epinephrine can be used as a first-line vasopressor. So also epinephrine in some situation now is mentioned a first-line vasopressor. So I think that this is a significant change in the vision that guidelines have for epinephrine. Noradrenaline effects are very interesting, increased blood pressure because the alpha-1 effect, increased venous return, increased preload, increased cardiac contractility because it has some beta effectors. But of course, they have some not so interesting effects like they can compromise microcirculation, can alter immunity, and also can increase the coupling of the ventricular arterial system. Also, you know that for adrenaline and also for noradrenaline, for both drugs, the response, the endothelial response is variable because the receptors can be downregulated. And also we know that this drug induce, like excessive fluids, induce more endothelial damage. So how we can help the patients knowing that high dose of norepinephrine or high dose of epinephrine may damage the patient. The first drug that we can use is steroids, because in both studies, the both biggest study that we have with steroids show a reduction in the dose of norepinephrine. And that's why in this edition of the guidelines, we suggest for patients with septic shock to use hydrocortisone. This has been revisited, no new papers in this area, but in fact, we keep the recommendation. And the other alternative, or in front of using a single vasopressor approach, is to use a multimodal approach. Multimodal approach has not been tested, so we have to rely in studies that instead of going for multimodal in front of single agent, is to studies that have additional vasopressors. For vasopressin, there is a lot of evidence accumulated since the last two editions of the guidelines. This is the timeline of many studies, including studies with machine learning that assess dose, time, etc. And under my opinion, patients should receive vasopressin when norepinephrine reaches 0.25, especially if the patient is at high risk of cardiac arrhythmia or stress. So in this advanced management of patients with septic shock or even refractory septic shock, we need to assess fluid responsiveness. For that, the recommendation is to use dynamic measure. We need to see the trend in lactate and capillary refill time. We need to keep resuscitating the patient only if the patient is a fluid responder. And as I said, noradrenaline in combination with vasopressin, in combination with hydrocortisone, is the best alternative if the patient is vasoplegic. Epinephrine can be a third-line agent, and if the patient has cardiac dysfunction, epinephrine can be the first-line vasopressor or can be combined with the other vasopressor, or the alternative is to combine the vasopressors with dobutamine in patients with myocardial dysfunction. A small room for angiotensin II. You know that angiotensin II is an alternative because patients with sepsis have reduced activity of the converting enzyme, and they have impaired activity of the receptors and increased degradation of angiotensin II. Angiotensin II and vasopressin has a better renal profile, but some patients do not respond, and we have to test the response to angiotensin II and focus in patients that are responder to angiotensin test, or in patients that we know that are taking ACE inhibitors, or patients with high levels of renin. So there's some room for this drug, but according to the guidelines, will be like the fourth-line vasopressors nowadays. I mentioned myocardial dysfunction is a component of septic shock, specifically, let's say, refractory septic shock, and also some patients may develop ARDS and right ventricular dysfunction. If the patient has ARDS, and specifically if the patient has right ventricular dysfunction, ECMO-BB is recommended, and in fact, this is a carryover for the previous edition of the guidelines. However, there is no recommendation for ECMO in patients with myocardial dysfunction, and this is quite surprising to me because there is only recommendation for inotropes, as I said, but not for ECMO. I can tell you that there are some evidence that ECMO-BA can be a cardiac support in some patients that have myocardial dysfunction, cardiogenic shock in the setting of sepsis, but of course, still, this is observational data, case control studies, and has not been included in the guidelines. But this is really a challenge. And the last topic I want to discuss with you, and I'm not going to take more than 5 minutes, is the use of anti-inflammatory drugs. Inflammatory drugs can help if the patient is hyperinflamed, drugs or devices, but of course they do not have to modulate the capacity of the host to control the infection. The list is huge. We didn't assess all these therapies in the guidelines, but we assess a quite long list, as you can see here. And as you can see in the slide, most of the recommendation is suggest again, suggest again, suggest again, suggest again, suggest again, and suggest again. So no positive recommendation for any of these anti-inflammatory strategies. This is a little bit frustrating. I want to explain you that a suggestion against means that you can treat some patients, not the majority of patients, but you can individualize therapy. And if you think, and the patients also agree with your approach, that the patient may benefit, you can do it. Suggestion doesn't mean that it's forbidden. This is an example. This is a PICO question for blood purification. So PICO means population, adult patient in septic shock, intervention, blood purification, comparator, usual care, outcome, mortality, and others. And when you look to the outcome in this PICO question and blood purification, you can see that in 28 days mortality, there is some benefit. There is a reduction in mortality at 28 days. But however, because this has cost and may compromise some factors like equity, the recommendation or the suggestion was a suggestion against, as I'm saying, both for blood purification, both for polymyxin B hemoperfusion. But I have to insist that you have to go for a personalized approach. Maybe some patients may benefit. You know to know well the device, what the device is doing, and to select well the patient, and to apply an excellent therapy in terms of dose, timing, patient selection, if you want to see some benefit. I want to stress this very, very recent publication coming from US. You know that polymyxin B hemoperfusion, we don't have a recommendation because the main trial was Euphrates was a negative trial, but a post-hoc analysis was the trigger for a new trial called Tigris. And for Tigris, the investigators used a Bayesian approach using data from the previous Euphrates trial and combining the results with the new trial called Tigris. So they add 150 patients to Euphrates, to the subgroup analysis of Euphrates, and what they found is a lower 28 days mortality. As I said, the analysis was Bayesian, and Bayesian analysis said that the probability of having a benefit is 95%, but for 90 days mortality, the difference is higher, and the Bayesian analysis said that the probability of benefit is 99.5%. So going for this personalized approach, because Euphrates and Tigris use levels of activity of endotoxin, the therapy has been positive. And it's important because we don't have many positive results. Also for steroids, I mentioned steroids for shock, but steroids for severe CAP also have positive results, and I have to insist that patients with severe community-acquired pneumonia may benefit for steroids. And then there's a specific subgroup of patients with sepsis called macrophage activation light syndrome, which are patients with multi-organ failure and liver failure, that there is also a recent positive trial by Evangelos Yamarelos and the group of Greece showing an improvement in organ dysfunction, specifically in patients with macrophage activation syndrome that receive anakinra. And those patients were selected based in ferritin levels. The last therapy I want to mention to you is immunoglobulins that also have a suggestion against, but again, specifically IgM-enriched immunoglobulin that have more scavenging and neutralizing properties and also modulate the host response, have demonstrated in this small study an improvement in organ failure when the patient has hypogammaglobulinemia. So this is my last slide to say that in my department, despite the guidelines suggest against many of the recommendations regarding inflammatory therapies, we are using some of them in certain group of patients based in different biomarkers. For example, ferritin above 4,000, we are using anakinra, but also in patients with hypercytokinemia, we are using cytosorban. In patients with high endotoxin activity, we are using polymyxin B hemoperfusion. And also hypoglobulinic patient in my department receive gamma globulins, and if we can acquire that IgM-enriched immunoglobulins because they are not available in Spain, we have to import that. And if the patient has a low flow subphenotype with severe cardiac dysfunction, we use veno arterial ECMO to support those patients during this period. So thank you to my team. Thank you for your attention, and you're kindly invited to our meeting in November, even in Barcelona in presence or online if you want to do it virtually. Thank you.
Thank you so much, Dr. Rickard, for that invaluable keynote. We truly appreciate your insights and your time today. And I'd like to share that already we have 196 participants here. No, 197 already. So it's a huge response, and there are lots of questions. I can't take a lot. Rickard, are you there?
Yes.
Oh, okay. So I think we can take, at least one or two questions I can take, because we have panel discussions also. So there is a question from the audience, that is Dr. Muhammad Maruf Hassan. The question is, what is the current status on early albumin use alongside crystalloids in septic shock?
So the question is about albumin?
Yes, early albumin
okay.
use.
So now there are two trials that are still not published, but I have the suspicions that are not published because the results are neutral. So still the recommendation is based in the Albios trial, that is a little bit old and in fact has been included in 2021 recommendation. So there is not strong evidence in favor of use of albumin, but if the patient have received an important amount of crystalloids, specifically if the patient is hypoalbuminemic, and if the patient, of course, if the patient have liver disease, those are patients that we are treated with albumin 20% in our case.
So I think there is another question, and that is actually when to measure lactate in new sepsis guideline.
And the guidelines are recommending to measure lactate again in the first hour, and to use lactate to guide resuscitation, but also because of the Andromeda trial, capillary refill time can be an alternative. But of course, capillary refill time should measure properly. You know that there is a specific technique for that I'm not going now to insist, but there is a specific technique for that. They have to do it properly, and can be a good alternative if you cannot do lactate. If you can do lactate, I suggest to do lactate.
Okay. So another question is, why anaerobic coverage antibiotics are discouraged? Is it due to increased risk of reducing commensal useful bacteria?
Yes, this is the point. So if you don't need to cover anaerobes, because anaerobes is not in the list of potential microorganisms causing this sepsis, please try to choose an antibiotic that do not cover anaerobes. If you can. Sometimes it's not possible because, of course, if the patient has a microorganism that needs a carbapenem, for example, you have to use a carbapenem. But if you can choose Cefepime or another cephalosporin that do not cover anaerobes, it has been demonstrated that try to preserve the commensal flora, the microbiome is positive. So that's why we add this suggestion in the guidelines.
Okay, so I think we have lots of questions. We'll try to get it from panelists also. So thank you so much, Rickard. We are already, it's been 1 hour, and I know people are very interested to listen, hear from you. And definitely, I'm sure that we will invite you again, and you will give us valuable time. So thank you so much, Rickard. Thank you so much. So now I'm excited to dive into our panel discussion. We will be exploring adjuvant therapies in sepsis, hope, hype, or next frontier. So as a panelist, we have today Dr. Subhas Prasad Acharya, Dr. Anushka Mudalige, Dr. Pradeep Rangappa, Dr. Yash Javeri, and Dr. Tasin Salam. So all are there?
Yeah.
Okay, so thank you. So let's start with Dr. Anushka. So what do we truly mean by adjuvant therapy in sepsis?
Thank you very much, Lopa. That's a good question. I think Dr. Ricard has already answered this question. But to say it simply put, like sepsis is when there's an infection in the body and it causes symptoms and manifestations. And from the beginning, we thought treating that infection would actually get that patient better. But then later on, we discovered that there is something else that's taking part in the body, that is a dysregulated host response, which has many components. Hyperinflammation, there is capillary damage, there is coagulation dysfunction. So that is happening from the body side. It's not due to the infection. So while treating the infection is the core management in sepsis management, apart from that, we have to treat whether to treat the host response, to control the host response, is what is called adjunct therapy. So adjunct therapy is not just to treat the infection or eradicate the infection. It is to bring back the physiology back to normal. I hope that that was clear.
So if anyone wants to add with Anushka?
Yeah, I'll add
Yes.
something. So the
Yeah.
concept of adjunct therapy is what we borrowed from oncology. Many of the principles of sepsis have been borrowed from oncology, including the PIRO model. Same applies to adjunctive. Despite best of sepsis guidelines, best of the therapies which we give for sepsis, the mortality remains high. That is why we needed a therapy which can decrease mortality and morbidity. And the adjuvant therapies primarily are used for the potential to decrease mortality. They are not the primary therapy, they are adjuvants. Thank you, Dr. Lopa. Thank you, Dr. Anushka.
Thank you, Dr. Yash. So my second question to Dr. Pradeep Rangappa. Are adjuvant therapies grounded in science or driven by wishful thinking?
Yeah, good evening, everyone. So after the excellent talk from Ricard Ferrar, so very nice talk, and we got a good insight into the latest in the sepsis. And I think Ricard Ferrar has already answered most of the questions Lopa would be asking us. The whole point of adjunct is there has been multiple trials over last 20 years. More than 100 trials have happened in various adjunctive therapies. But what we have clearly understood, I'm sure all of us have very clearly understood, sepsis is not one pathway. So there are multitude of pathways that are involved, and one molecule has always failed. So there are anti-inflammatory pathways that are targeted. There are endotoxin sort of a pathways that are targeted with pharmacological molecules and with the extracorporeal removal of this. Then there are coagulation pathways that are targeted. Then there are immunostimulatory sort of a pathways. Then there are contemporary molecules like statins, immunoglobulins, and vitamin C as well. And we have seen even with a simple molecule like vitamin C, there have been at least 10 trials. The first one, although raised our enthusiasm, we were using vitamin C based on the initial sort of a study that came, which was a not a randomized control. So based on that one study, there was a huge enthusiasm. But then we witnessed after the vitamins trial came, after the Vitcal trial came, so it miserably failed. All the subsequent trials really did not show. So although these molecules have an initial excitement and enthusiasm in animal studies, and they have a very, very robust sort of a scientific plausibility because they do sort of convince us that physiologically they do function. But when you extrapolate it into big sort of a clinical trials, most of these molecules, as Dr. Ricard has shown, have failed miserably to show our definitive endpoints that we look at, which is mortality, length of stay, and some of them, like extracorporeals, they have shown certain numbers improve, the hemodynamic stability, even the steroids. If you see, I think not necessarily they've changed the endpoint of mortality, but they tend to have a little effect on vasopressor sparing effect and some physiological endpoints. So that's where we are at. But that shouldn't dissuade us in continuing our efforts and zeal to look for the molecules which possibly will act in a multimodal way and try to save more lives. That would be my submission, Lopa.
Okay. So thank you, Pradeep, for your excellent answer. So my third question to Dr. Yash Javeri. Has the search for a magic bullet advanced or distracted the field?
Thank you, Dr. Lopa, for a very interesting question. We practice science, we do not practice cult science. And after, say, 50 years of research into adjuvant therapies, we understand there are no magic bullets, there are no holy grails. The whole sepsis saga and the COVID saga, we understood there are no magic bullets. Sepsis pathology is very, very complex. So if we think about a monocausal treatment or other adjuvant therapies for sepsis, it's very, very difficult. And as discussed previously by Dr. Rangappa also, the big data analytics fail it. There was a war general, H.L. Mencken. He said, for every complex problem, there is an answer that is clear, simple, and wrong. So we cannot have shortcuts for treatment of sepsis. We must have a very, very firm adjuvant therapy which has a very firm clinical basis to it. However, what have these adjuvant therapies taught us? They have undeniably deepened our understanding of sepsis pathology. We understood what to do, what not to do, what is the right way forward for sepsis treatment. Adjuvant therapies have also driven our exploration into immune modulation, endothelial dysfunction, and microcirculatory function. So, whether magic bullet concept of sepsis treatments have advanced or distracted the field, I will say we have advanced. We have advanced in our understanding of sepsis pathology. We have advanced in terms of therapeutics. We are better equipped knowledge wise to do the right thing and to avoid the wrong things. So we have moved from cult science to real science in sepsis with the help of concept of adjuvant therapies. Thank you.
Okay, so very beautifully explained, Yash, because we are in confusion with lots of things. So thanks for clarifying it. So my next question to Dr. Subhash Acharya. Subhash is also in guideline, and I'm so happy that Subhash is representing our Southeast Asian region. Recently, he worked in a wonderful paper with George, Javier, and that's nice. So, Subhas, why this adjuvant research called the graveyard or clinical investigation?
Thank you, Lopa. Thank you for the introduction and having me here. As we all know, there are so many therapies that have failed in phase 3 trials. So I think that's the main reason it's called a graveyard. But if we see, it's not only sepsis. This happens in many other conditions. So given the amount of research that's happening in cancer and molecular therapies, I think in sepsis we are still very far behind and not much research has been done in sepsis. Other examples includes like dementia, Alzheimer's, autoimmune disorders. So many trials, research are going on, and so we still have a lot more to do. But I think basically the failure of this trial result could be because of many things, as we already discussed by previous panelists and speaker. Sepsis is not a disease. There is heterogeneity, and the treatment response is very different. And also talking about trial designs, it's very difficult to encompass everything related to sepsis. Like the trial cannot account to timing or the phenotype or the disease trajectory. It's very difficult to have that. So that will result in basically dilution of the potential benefit of the study, and thus many promising intervention that what we feel or we felt that this would work later demonstrate to fail any clinical benefit in these patients. Thank you.
Thank you, Subhas. It's nice to hear from you.
Dr.
So my
Lopa,
next question to Dr.
if I
Tasin
can
Salam.
add a small sentence.
Of course, yeah, sure.
Yeah, thank you. So although the sepsis adjuvant clinical research is epitomized as graveyard of clinical research. It is not like that. Our understanding about sepsis pathobiology is getting better with every failing trial also. Every trial teaches us a lesson. We might not be having happy ending trials, but the lessons from these trials are important to move in the right direction. We understood the value of genomic groups, we understood the value of single centric trial, we understood the value of the real outcomes. We must look at the right surrogate endpoints. We must not look only at 1 month or 6 month and survival. Also, we have to understand that absence of evidence should not translate into evidence of absence in terms of survival benefit with adjuvant therapies. Thank you, Dr. Lopa.
Okay, so my next question to Dr. Tasin Salam. Does biological plausibility justify the continued enthusiasm?
Thank you, Lupa, for arranging such a nice gathering, and thank you, Ricard, for having a very nice presentation. So one thing before answering my question, I like to share that when the sepsis is a very mortality disease. Whenever the new guideline come, I always go for the adjunct therapy first, because the fluid resuscitations, the ventilator, these are the things we always know and it's very for sure. But I always look for the adjunct therapy. Is there anything new? Is there anything new which we can do to reduce the mortalities? But whenever we see the things, we just get little unhappy that the trial doesn't have that good, very mortality rate. So the question Lopa asked is that if we go through the sepsis pathology, it is not a single disease. Already Shubha says that is a heterogeneity, is very complex things. And patient response is not that kind of very linear. And this kind of thing always difficult to give the single drug which can give a very good benefit. So though we are very much waiting for is there any good biologics come and give some good result. If you look back to some RCTs around the activated protein C anti-TNF factor, they do not give good mortality benefits. So I think we need more good RCT around these things to give the good results. That's the thing.
Yeah. So thank you so much, Tasin, because what I know that as LMIC, we are always searching for something new, that at least low cost interventions also we are always looking for. That is also an important thing. So my next question to Dr. Yash, has the journey been promised undermined by disappointment? Please try to short your answer, because
Yeah. Thank you. So the journey of adjuvant therapies in sepsis has indeed been marked by cycles of promise and disappointment. Small RCTs, very promising, big data analytics failed us. But each failed trial has contributed valuable insights into disease complexity, and we learned tremendously from the failed trials also. We learned the importance of timing, dose, metabolomics, genomics, and patient heterogeneity. And these lessons are shaping more refined and targeted research approaches. Thus, what appears as disappointment is often a step towards deeper understanding, and this is the way science should progress. This all was seen in a very short duration in COVID. One therapy failed by science, another therapy which was very promising failed by science. But gradually we learned what is right and what is wrong. And same is happening with sepsis. Thank you.
So, Anushka, can you tell me to what extent has industry shaped the agenda?
Yeah, thanks. Very relevant, timely relevant, Lopa, that question. Yes. So industry plays a major role, I think, in the current research and development of medications that we have talked all this time. So one thing is they fund all the major trials that they did. They help with the funding, because we know how much funding is needed to carry out all these trials. And also they have innovation that bring up the novel therapies which we use in the trials. So in these two ways they do contribute a lot. But however, because of this involvement, they can influence and give attention and momentum to certain therapies, whereas the other therapies might not get that attention. So this commercial interest and scientific evidence, they always have this conflict. So I think the way forward is you cannot deny either. You have to have a balance between the two and make sure the scientific method always gets the guiding principle.
Okay. Subhas, my question to you is, are adjuvants victims of poor trial design and heterogeneity?
Poor trial designs, not necessarily, because we know there are very now well conducted trials like the vitamin C lobby trial, like they are well designed studies. So not necessarily, but syndrome heterogeneity, definitely yes. And the diverse biological phenotypes in sepsis, they all are grouped together in trials. So that's, as we discussed, leads to potential dilution of the potential treatment effects. So I think if we are to conduct future studies, trials, we must incorporate biomarkers, adaptive design, and stratifications, so that we come up with some positive results.
Okay. So Dr. Tasin, can you tell me, beyond steroids, what credible options exist today? I mean, for our countries also. So can you just highlight it?
That's already discussed, but steroid is one of the best adjuvant, I think. But other than we were from the last 2021 guideline, we are using the vitamin C and along with the berine, and also we're using the vitamin D, and some specialist center we are using blood purification techniques. But whatever we are getting in these guidelines, that none of them has very good mortality benefit, though blood purification has some benefits, but still this is not very conclusive. But I think in some specific case, in a specific condition, that gives us some benefits, those really like those who really have IL-6, very high IL-6 or something like that, very cytokine storm. I think these are the place where we can use the adjuvant therapy for the conditional stages. That's the thing.
Okay. So Dr. Pradeep Rangappa, can you just tell me that strength of evidence for extracorporeal therapies and immunoglobulin?
Thanks, Lopa. I think as Dr. Ricard already showed, I think when we started with extracorporeal, the whole enthusiasm was with the endotoxin adsorption. And we got that UFAS trial, which was done in intra-abdominal sepsis by Italian group, that showed and raised our enthusiasm about role of this endotoxin adsorption in specific group of intra-abdominal sepsis patients. And after that, a big multicentric trial came, which was Euphrates, which Dr. Ricard showed, and that was a negative trial. And just to obviously tweak with all the numbers, so the Tigris trial came. So in fact, we were part of a trial where endotoxin levels were being done, so to include the patients in the study, and we found that even the assay was fairly skewed and not necessarily it correlated with the severity many a time. So there were a lot of issues when we deal with these studies, but although the meta-analysis and most of the studies of this polymyxin B hemoperfusion, especially with the meta-analysis, if you see, which showed some positive signals, they all came from Japan. Around 10 studies came from the Japan. So to that effect, as Dr. Ricard said, maybe there is a specific subgroup or cohort of the patients where these may benefit. But at this point of time, there's no conclusive evidence to make this as a standard of care for all sepsis patients. So that's where this extracorporeal hemoperfusion rests. And even with cytokine absorption, so there also small done analysis incorporating these small studies show signal, but mortality endpoints are being very dissuading and disappointing. Although there has been signals that usage of these would possibly achieve your hemodynamic endpoints better. So having said all that, the timing of using this also becomes a huge contention, so we'll not get into that. So with regards to IVIG, Again, there are multiple studies. I think one good trial was the SPITS trial that came in 2017. Again, it did not show any mortality benefit. And the mother of all trials, like Cochrane review, which has reviewed all the immunoglobulins in adults, that also has not shown any mortality. Although in kids, it's a different narrative. But in adults, at this point of time, IVIG has not shown any benefit with regards to mortality and cannot be recommended as standard of care. So these are my submissions.
Okay. Thank you, Pradeep. It's very nicely. Yash, can you tell that innovation or Me Too therapies? I must say, because very important for us, because we get lots of patients, actually, they come very late to us with sepsis. So that's very important because we want to know that.
Thank you, Dr. Lopa. So most of these therapies are failing in big data analytics. We have tried different means to achieve immunomodulation. The ultimate aim is to bring the host to a lesser degree of immune disarray. It could be with extracorporeal removal, hemoabsorption, vaccines, antibodies, everything has been tried. Although we call them Me Too therapies because the ultimate result what they want is immunomodulation, but the mechanisms to achieve these are different. So they are little innovative in true sense. In the field of sepsis adjuvants, these Me Too therapies reflect both genuine innovation and incremental repetition. We learn a lesson from one therapy, we try to apply it to another subset of therapy. So some of these therapies represent novel approaches, but some of them are repetitive. Others are variations of existing concepts. However, true innovation must translate into meaningful clinical outcomes. Whatever we use, whatever the physiological rationale might be, we should translate this into meaningful clinical outcomes. Without that, novelty alone cannot justify widespread adoption. Unless we have outcomes, our outcome scores could differ, our surrogate endpoints could differ, but we need to have good clinical outcomes. Thank you.
Okay. So actually, Dr. Tasin, are we looking at the wrong endpoint in very few words because we are running out of time?
I know you're running out of time.
Yeah.
So what I see, most of the trial is go through the mortality benefits, but actually sepsis is not a single disease, it's a syndrome or the heterogeneity, and the mortality is depends on these different things like the patient age, frailty, immunities, and also the condition of the ICU and the timing of presentation. So I think this is a time to address, along with the mortality, the organ dysfunction based outcomes and patient-centered outcome that will create more compact compact management. I think so. This is my submission.
Okay. So Anushka, in a few words, is mortality too crude at endpoint?
Very right.
Yeah, I think Tashin already answered this. Says yes, I already agree. Mortality alone is not a good outcome to see. It is one of the main ones, but additionally, as he said, other patient outcomes like organ dysfunctions, how soon the patient comes out of the shock, and then the functionality of the patient later on. These all should be included. This should not be denied of. So composite and functional outcomes should be included along with mortality. I agree with Tashin.
Okay. So Subhas, can you tell, should future therapy be phenotype driven?
Definitely yes. Rather than one size fitting all approach, because we have seen the failure of one size fit approach. There are so many reasons of that magic bullet failing, because we all have talked about heterogeneity. There are significant variations in organisms, immune response, comorbidities, and even the immune spectrum. Like patient can present with a hyperinflammatory or even a hypoinflammatory state. So one treatment might not, which works in one patient, may not work in other patients. And we also have seen advantages of phenotype-driven therapy also. So there are targeted therapies which were tailored to the patient immune status or underlying pathophysiology. That will definitely be more promising. There are example of soft phenotypes which have been identified, which I don't want to go into detail, but there are studies which have identified soft phenotypes, and thus the advances in biomarkers and genomics has now allow us much more better patient stratification. Targeted therapies based on phenotype would definitely enhance treatment efficacy, and precision medicine represents the future of sepsis management.
Okay. So just Pradeep, can you just tell us hopeful future or time for skepticism?
Skepticism. Yeah, thanks, Lopa. I think this answer for this is very nicely encapsulated by our Yash, our good friend Yash, that every trial, like more than 100 trials in last 20 years on adjunctive therapies. So what has that showed us? It has really showed us that one molecule targeting one pathway doesn't help. We need to understand the host. And the whole definition of sepsis is life-threatening organ dysfunction due to dysregulated host response. So we are now trying to calibrate our treatment to the host response. To that effect, the whole effort, as Subhash has rightly said, is to phenotype the patients, trying to see whether they are in a hyperinflammatory phase or whether they are in immune suppression phase. Because if you look into the epidemiology of sepsis over last many years, more deaths, if you take 40% as mortality, around 30% or maybe a little less would happen in the most post-immune paralysis or post-sepsis immune paralysis or immune suppression, not in hyperinflammatory. So given that standpoint, it is important to categorize the phenotype and maybe using multi-omics. I think that is the future, trying to integrate all the different host variables and calibrating the treatment to the host is the way forward. And this is the only way. That is where our studies are failing because of hugely heterogeneous. We are not dealing with all humans as one. So we have clearly understood every human is distinctly different, and we need to calibrate treatment to their response, which is only possible by large data integration, which is multi-omics. So these are my sort of viewpoints, Lopa.
Okay, so I think there are lots of questions from attendees. Ricard, I think you are also there.
Yeah, Ricard is here.
Oh, okay. So there is a question from our good friend, Dr. Ranajit Chatterjee. He was saying that we using hemoperfusion, CRRT, immunoglobulins against the guidelines. How do you defend this? Again, are guidelines really guidelines or otherwise?
No, I insisted in my talk that using is not against the guidelines. So you have to understand what is suggestion and what is recommendation. Suggestion or weak recommendation in favor or against. In fact, in favor or against is sending the same message that you have to personalize the therapy, you have to look for the right patient. Also, you may discuss with your patient which are their values, which the patient want, and then go for a more individual approach. So it's not, if it's a strong recommendation, maybe you are doing something that really the guidelines are not encouraging, but doing something that is suggested, you really can do it, and the guidelines consider that this is possible.
Great. So another question, that is, how early should we start adjunctive therapies, as we are always late and usually regret after spending a lot? Ricard?
Yes, no, the first step is to start with antibiotics or control hemodynamic monitoring. You need some time for that. After a few hours, you have to reassess. Is the patient receiving the appropriate antibiotic? Is source control completed? Is my patient not unresponsive to fluids? Have the right dose of vasopressor? Has the echography done? It's completely hemodynamic monitored, and you know that cannot be optimized. If this patient that you have checked and rechecked the 3 pillars of sepsis treatment, if the dose of vasopressor is increasing, then it's the time to start adjunctive therapy. So reassess the patient, and maybe a window of 6, maximum 12 hours is a good window to start adjunctive therapies.
Yeah.
Okay,
Lopa,
thank
just
you
one
so much.
sentence to add. One sentence to add. Although
Sure.
Dr. Rickard explained the physiology, when to use it, it should be timely. It shouldn't be very early, and obviously it should not be very late. Most of the patient,
Yes.
it has to be timely, and select few who are high risk, it could be little early. Yeah.
Okay. So I think now we can actually summarize the session. Thank you so much, Rickard, for being with us and taking the questions from audience also. So in next session, or we will do something, with our new questions also. So can you summarize, Yash,
Yeah.
in few words,
Yeah.
the
Yeah.
whole
Yeah.
panel discussion and today's topic?
Thank you.
1
Thank you,
minute.
Dr. Lopa. Thank you, Dr. Rickard. Thank you, World Federation leadership and others who have joined us. We are wiser today. We understand adjuvants have very firm physiological rationale. We must understand when, what, and how to use it. It has to be judicious, individualized, and personalized. We must individualize it to target phenotypes. We must look at the right endpoints. Probably we are looking at the wrong endpoints. We must decouple RCTs, and absence of evidence should not translate into evidence of absence. And we should not desire too much from adjuvant therapy. They are just adjuvants. They must do what they are supposed to do. There are no magic bullets. Thank you, Dr. Lopa.
Thank you so much. To close this wonderful session, I would like to again invite our respected Professor Dr. Kamruhuda sir, President of Society of Intensivists, Bangladesh. Over to you, sir.
Can you hear me?
Yes, sir.
Yes, sir.
Thank you very much. Thank you, Dr. Lopa. Wonderfully moderated the session, and I'd like to congratulate the speaker, Richard Ferrer. He has fantastically explained, and it has become much easy to understand all the population. So I'd like to congratulate him once again. I'd like to congratulate our patron, our president of WFICC, and I'd like to congratulate all the panelists who have participated. And that is very lively, and that is very insight was very deep, and I could able to learn many things from you, all of you. And most probably, I list our participants from Society of Intensivists Bangladesh. I congratulate all the participants, those who have participated. Almost around 200 population had participated this session. So I like to congratulate all the population, and we hope for better management of the patients from suffering from sepsis. And we would once again, I request all the population to arrange such organization once again to learn more and more, and to be kind to the population of those who have been suffering for such diseases. Thank you very much. Thanks to all of you.
Thank you so much. Thank you, everyone. Thank you, all the panelists. Thank you, sir. And Rickard, our keynote speaker, President, World Federation, and all. So see you soon with something new, with webinar. And Society of Intensivists Bangladesh is committed to do many scientific programs, collaborated with global partners. Thank you so much.
Thank you.
Thank you very much.
Thank you very much.
Thank you.
Thank you.
Bye-bye. Good
Thank
night.
you.
Good night. Good day,
Good
everyone.
night.
Bye-bye.
Are you there, sir? Kamruhuda, sir?
I am not leaving.
Oh,
I'm
sir is
present.
here. I was just so
Yes, you can.
actually, definitely, sir, we need to congratulate more to BD physicians. Dr. Ehsan is here.
Oh,
He
thank you very
just helped us. He just supported us, and actually, I mean, the success of today's webinar definitely with BD physicians. And Habiba was there, and Dr. Ehsan was there. So thank you so much to Dr. Ehsan also.
So, on behalf of you, and I congratulate all the population. Thank you very much. Thank you. See you once
Thank
again.
you.
I'll discuss issue.
Okay, thank you.
Okay, thank you.
Okay, good night.